Hello, today we're going to talk about anxiety disorders. There are several anxiety disorders that we will be discussing, and this will be one of two tapes or videos rather that will be presented. Now, these slides were made when the DSM-4 was in place, but it has some good information, and so I'm going to go through these first and then I'll update with the second video. The disorders we're going to talk about today is generalized anxiety disorder, panic disorder with and without agoraphobia, specific phobias, social phobias, post-traumatic stress disorder, and OCD. With anxiety disorders, generally the treatment is going to be antidepressants and anti-anxiety medications. Now, the go-to anti-anxiety medication are benzodiazepines. Those are things like Xanax and Librium. Now, one of the bad things about these is they are extremely leads a person to dependence, substance dependence. They're very addictive. And so that's one of the downsides, and yet it is one of the first go-to medications that doctors will usually start working with. The effective treatment for anxiety disorders, they're available, and the anxiety disorders are still under research for more improved medications and therapies. And with medication, with therapy, with help, people can lead a very productive, fulfilling life even if they do have anxiety disorders. The first anxiety disorder we're going to talk about is called generalized anxiety disorder. It's abbreviated as GAD, G-A-D, and it's referred to as GAD. Now, GAD is really a free-floating anxiety. They have a chronic underlying anxiety almost all the time. They're chronic worriers. If there's nothing to worry about, they'll worry about having nothing to worry about. And so free-floating anxiety, a constant chronic anxiety that is with them a great deal, if not all the time. GAD is an anxiety disorder characterized by chronic anxiety, exaggerated worry and tension, and these happen even when there's little or nothing to provoke it. Now, one of the ways that you can tell somebody has GAD is if their body is exhibiting constant tension, like if they're always tightness in their shoulders. They may complain of shoulder aches, back aches, neck aches, even headaches when there's no other reason to explain it. Here's a quote from somebody who had GAD. "I always thought I was just a worrier. I'd feel keyed up and unable to relax, and at times it would come and go, and at times it would be constant. It could go on for days. I'd worry about what I was going to fix for a dinner party or what would be a great present for somebody. I just could not let something go." Well, this is a disorder that spans many countries. Australia, about 3% of the adults have GAD. Canada, between 3 and 5%. Italy, about 3%. Taiwan, 0.4%. And the United States, 3.1%. And that's between age 18 and over. About 6.8 million. Now, I guess one of the questions in looking at this slide is, what is it about the culture or the way of life in Taiwan that helps them not to have GAD as frequently? Signs and symptoms of people who have GAD. People with generalized anxiety disorders can't seem to shake their concerns. Their worries, they're accompanied by physical symptoms, especially fatigue, headaches, muscle tension, muscle aches, difficulty swallowing, trembling, twitching, irritability, sweating, and hot flashes. I'd have terrible sleeping problems, said one person. There were times I'd wake up wired in the middle of the night. I'd have trouble concentrating, even reading the newspaper or a novel. Sometimes I'd feel a little lightheaded. My heart would race or pound, and that would make me even worry more. I was always imagining things were worse than they really are, or were. And when I'd get a stomach ache, I'd think it was an ulcer. People with GAD, they'll go through the day filled with exaggerated worry. They'll go through the day filled with exaggerated tension, and even though there's little or nothing to provoke it, they will anticipate disaster. They're overly concerned about health, money, family problems, difficulties at work, and sometimes just the thought of getting through the day will produce anxiety. GAD, it's diagnosed when a person worries excessively about a variety of everyday problems for at least 6 months. People with GAD can't seem to get rid of their concerns, even though they usually realize that their anxiety is more intense than the situation warrants. They can't relax. They'll startle easily. They have difficulty concentrating, and often they'll have trouble falling asleep or staying asleep. Now that is actually the definition of insomnia, having trouble falling asleep or staying asleep. So they can't relax, they startle easily, they have trouble sleeping and concentrating. They'll often have fatigue, headaches, muscle tension, muscle aches, difficulty swallowing, trembling, twitching, irritability, sweating, nausea, lightheadedness, having to go to the bathroom frequently, and sometimes even feeling out of breath or having hot flashes. Now, I'm not going to go through this criteria for the DSM-4 because it is out of date. GAD, again, affects about 6.8 million adult Americans. About twice as many women will have it as men. The disorder comes on gradually. It can begin across a life cycle, and then through the risk, though the risk is highest between childhood and middle age, it can occur in just about any age group. There's evidence that genes may possibly play a role in GAD. Some of the potential causes: some research suggests that GAD may run in families. It may grow worse during stress. GAD usually will begin at an earlier age, and symptoms may manifest themselves more slowly than in any other anxiety disorder. Some people with GAD will report the onset in early adulthood, and that's usually in response to a trigger or a life stressor. Once GAD develops, it can be chronic, and it should be noted that it can be managed, if not all but alleviated, with the proper treatment. What are the treatments? Well, first of all, cognitive behavioral therapy is very effective. In fact, it's basically more effective in the long run than pharmacological treatment. CBT, cognitive behavioral therapy, is the most effective treatment in reducing depression. Again, other treatments, they can give anti-anxiety medications, and again, some of the antidepressants, which would be your SSRIs. Panic disorder with or without agoraphobia. The symptoms: panic attacks. They involve short periods of intense symptoms, such as these listed that I'm about ready to mention, and they usually peak within 10 minutes after they start. Chest pain, chest discomfort, choking, dizziness, faintness, sweating. Now, what does that sound like? And you can even add nausea in that. sounds like a heart attack. Many times when a person has not ever had an anxiety attack before, when it hits, they will believe they're having a heart attack. They'll go to the ER, and the emergency room doctor will do tests and then come back and tell them they've just had a panic attack. So, symptoms of a panic attack: chest pain, discomfort, choking, dizziness, faintness, shortness of breath, sweating, fear of being out of control, a fear of dying, a fear of going crazy, hot flushes, chills, nausea, other stomach distress, numbness, tingling, palpitations, that's where the heart kind of flutters, shortness of breath, sweating, trembling. Now, all of those are symptoms of a panic attack. Now, again, I am not going to go over this criteria here because it is the criteria for DSM-4, and we are now under the DSM-5. The main feature of panic disorder without agoraphobia is an unexpected and recurrent panic attack without the accompanying fear of open places or being in places that they fear they can't get out of. The frequency and severity of these attacks, they're unexpected, they're recurrent, and they vary widely from individual to individual. Sometimes the attack will occur every day, sometimes once over every few months. Some attacks may be long, some may be short. These attacks come when they feel like it, and it will give the person a tremendous amount of apprehension about the next attack. One of the apprehensions is where it will occur and how embarrassing it will be when it occurs. It's common for panic attacks to occur in adolescence to the mid-30s for the onset. Less common in childhood or having the first one occur after 45. Panic disorder with agoraphobia. Women will experience panic disorder with agoraphobia 2 to 3 times more than men. The age of onset will usually start around 25. It can affect middle-aged and older adults as well. A panic disorder with agoraphobia is an anxiety disorder in which there are repeated attacks of intense fear and anxiety, and the fear of being in places where escape might be difficult, where help might not be available in cases of a panic attack. So a person that has a panic attack with agoraphobia, they are going to worry about being in a place that they can't get out of, or if they're there, there will not be the ability to be helped if something happens. The exact cause of panic attack or panic disorder is unknown. It seems to have to do with many factors, though. Panic disorder can occur with or without agoraphobia, but agoraphobia develops in more than 1/3 of the cases. Agoraphobia may be a learned behavior because it involves a fear of having panic attacks in unprotected settings. Sometimes panic attacks occur in areas where they have happened in the past. Panic disorder can occur in children, but it usually starts at age 25. It can affect middle-aged and older adults as well, but studies have shown that women are 2 to 3 times more likely to experience a panic attack or a panic disorder than men. Symptoms of agoraphobia: anxiety about being in places where escape may be difficult, avoiding situations with great stress, or anxiety about having a panic attack. Becoming housebound for long periods of time, fear of being alone, fear of losing control in a public place, feeling detached or separated from others and feeling helpless and dependent on others. If your panic attack has not been diagnosed, you may feel as if you are dying, that you're having a heart attack. Often people will go to an emergency room or urgent care center because they feel or think that they are having a heart attack. Physical examination and psychological evaluation can help the diagnosis. Symptoms can be physical and the condition can be misdiagnosed. That's why it's important to rule out medical disorders. Problems such as heart problems, hormonal problems, lung problems, nervous system problems, and even substance abuse. Also, these conditions can occur with panic disorders. The standard treatment approach combines cognitive behavioral therapy, which helps you to understand and change the thoughts that are causing the condition, and an antidepressant such as an SSRI like Paxil. That would be the first choice. Your SSRIs, other treatments are your SNRIs, your serotonin norepinephrine reuptake inhibitors. That would be like Effexor, and other antidepressants and anti-seizure drugs may also be used for severe cases. Anti-anxiety medications may also be prescribed. Again, that nasty little word benzodiazepine is coming up again, and this is because there's a real problem with these benzodiazepines, again, because they are so habit-forming and addictive in nature. Some of these benzodiazepines are like Alzepam, Ativan, Centrex, Klonopin, Librium, Serax, Valium, Xanax. All of these are benzodiazepines, and all of them are highly, highly addictive. Most people will get better with medications and cognitive behavioral therapy or some form of therapy. Without early and effective help, though, the disorder may become more and more difficult to treat. Now, we've talked about the panic disorder with and without agoraphobia. I had the very, very first case of panic disorder that I had that I treated was the first person that came to my clinic when I opened up for therapy services. She came in and she said that she was having a panic attack every week. And she said, without fail, I'm having at least one a week, but I can have more than one a week. Well, I got her to start keeping a journal. And I wanted her to keep a journal of when the attack occurred, what time it occurred, what day it occurred, what was she doing when it occurred, was there anything that made it better, was there anything that made it worse, and how long it lasted. Well, after a while, she brought me the journal, and sure enough, she was having a panic attack at least once a week, and sometimes more than once. Funny thing though, she was having it every Wednesday. And then I looked and she was having it every Wednesday at 12 o'clock. I was thinking that's when the tornado sirens go off. So I asked, have you ever been in a tornado? And she said, yes, I have. And I said, well, tell me about that. And she said, well, one day, it was in March, I was watching TV and they said that there was a lot of tornado activity south of us, and it appeared it was moving toward us. Well, I watched and I was not feeling any better. It looked like it was going to really get bad. So I went out and I looked, and it really looked like it was ominous. And so I got my baby back inside, and she said about that time the TV said, you know, there are tornadoes in the area. And so she said, I ran, I grabbed my baby, I grabbed a mattress, and I put it over me in the bathtub in the trailer. And she said the trailer, you know, it really started getting noisy, and the tornado alarms, tornado sirens started coming on, and she said the wind started blowing and rocking the trailer back and forth. It was getting noisier and noisier, and she said everything was just going crazy. And she said I was in that fetal position in the bathtub, and she said I was crying, I was scared, I was trembling, and she said I was hovered over my baby with that mattress over us, and I'm sitting there saying, God, please, please don't let my baby die. Please save my baby. Please don't let anything happen to my baby. And she said the trailer was just really giving it all kinds of stuff. And she said all of a sudden it got very quiet. And she said I waited for a little while. And finally I removed the mattress and I came out. And to the left, the entire block was leveled, and to the right, the entire block was leveled. And she said the tornado jumped our block. Well, there is a case of classical conditioned panic attack. Here, when she was in the middle of a tornadic activity, her trailer was being rocked back and forth. She was scared. Well, now, whenever she hears a siren, she has a panic attack. So, I started working with her, and I think I started using what's called systematic desensitization. We'll talk about that in a minute. But the fact is, that one had a specific trigger. That was panic attack without agoraphobia, but we were luckily able to identify what the precipitating event was that would start it. Now, we are going to talk about specific phobias. Now, phobia is a fear that is out of proportion to the danger, and even though the person may know it's out of proportion to the danger, they really cannot bring it down, okay? A phobia is a fear that is caused by a specific object or situation. The fear may be by an actual presence of, or by the anticipation of the presence of that object, and anxiety triggered by the fear may approach the intensity of panic. The patient will experience a long, persistent fear that's excessive or unreasonable. It will be cued by a specific object or situation that is either present or anticipated. The phobic stimulus will almost always immediately provoke an anxiety response, and that can be either a panic attack or symptoms of anxiety that do not meet the criteria for a panic attack. The fear is unreasonable, it's out of proportion, and it is not unusual for the patient to realize this. They may even say, I know that this is ridiculous, but I'm still scared of this. The patient then will either avoid the phobic stimulus or endure it with extremely severe anxiety or distress. The patient can be under this can happen to a patient under the age of 18, but it must have had the symptoms for at least 6 months or longer. Either there is going to be a marked distress about this fear or markedly interfering with the patient's day-to-day living. Symptoms, this occurs, they're not better explained by a different mental disorder or medical disorder. Some of these mental disorders that you have to rule out, dysmorphic disorder, pervasive development disorder, schizoid personality disorder, and even some of the other anxiety disorders. Now, this type of anxiety will have a specific stimulus. Now, they are categorized in several types. One is called a situational type, and this would be something like being scared to fly, claustrophobia, fearing being closed in. Then there's natural environment type, being scared of thunderstorms or being scared of heights. Then there's the type of phobia about blood, and they would fear being injected, looking at the hypodermic. They might get very, very upset if they pass a Red Cross trailer. They can also be fearful of seeing injuries and such. Then there's animal types, which would be like spiders or snakes or dogs. And other types would be situations that might lead to illness, choking, vomiting. You may have to do a differential diagnosis. Here, some disorders have similar or even the same symptom. The clinician, therefore, in diagnosing, has to differentiate or rule out the following disorders, which has to be done to have a precise diagnosis. Things that need to be ruled out: panic disorder, social phobia disorder, post-traumatic stress disorder, obsessive compulsive disorder, separation anxiety disorder, hypochondriasis, anorexia nervosa, bulimia nervosa, schizophrenia, or any other type of psychotic disorder. Now, phobias usually begin in childhood. A personal trauma or stress can trigger this phobia. An example would be a person who was once trapped in a small room. They might later become frightened or panicky in closed spaces. Also, I believe that vicarious learning can help a person to develop a panic disorder, especially if it's followed by some kind of trauma that would reinforce it. So, let's say that Mama is scared of dogs, and Mama, don't you dare get near a dog, don't you dare get near a dog. And she constantly says, dogs are evil, dogs are horrible, they'll hurt you. And then one time you get near a puppy and the puppy bites you a little hard, well, then that reinforced everything that Mama said. And then there is the seeds for the problems in later life. Genetic factors have been associated with phobias. Many people who have phobias may have relatives with similar phobias or symptoms such as fears and or tendency to avoid situations. Now, when you're dealing with genetic factors here, again, you have to make sure that you don't have to make sure, you cannot rule out the fact that there has been some kind of environmental learning. The treatment of phobias, this is one that you would basically use a behavioral therapy focus. Sometimes a drug therapy can be tried, but what I said a minute ago about systematic desensitization, that is a very, very effective treatment for these specific phobias. Now, systematic desensitization would be where, first of all, the therapist teaches the patient how to relax at a basically on demand. And after they get very, very good with that, then the therapist will say, what I'd really like you to do is to list 10 things associated with what you're really, really scared of, and I want you to list them in order of the thing that you would be least scared of to the one you'd be most scared of. Well, let's say that the person is scared of flying, and they bring them the list, and the first thing on the list is the word flying. Well, a therapist would go about and say, now look, here we are in a place that's perfectly safe. There's nothing that can hurt you in this room associated with your fear. Now, I'm about ready to say a word, and you may think that it is a word that you can be scared of, or that you're scared of, but it's not a word that you need to be scared of. And you just need to remember this is a safe place, and you're in charge of your fear. Your fear is not in charge of you. And so the therapist then will say something like, okay, flying. And the person goes, and the therapist will go, now wait a minute, remember, you're in charge of the fear. The fear's not in charge of you. You're safe here. There's nothing in this room that's going to hurt you with that word. And so they go over and over and over and over saying that word until the patient, pretty soon, the therapist will say flying, and they'll go, pfft. So then they move up to the next one. And the next one might be reading the word flying. And so the therapist goes through the same thing, might have a flashcard, and they'll flash that card, and the patient will go, and the therapist will go, now remember, that's the way you used to react when we'd say the word flying, and now you're not scared of that. There's nothing to be scared of with this word. This word cannot hurt you. You are in a safe place, and you are in charge of that fear. That fear is not in charge of you. And so they'll go over it and over it and over it until pretty soon the word can be flashed, and they'll go, pfft. Well, they keep it up, all 10 rungs. It might be showing a model of an airplane. It might be looking at a picture of an airplane. It might be driving by the airport. But each thing is going to elicit a little bit more fear, but they don't go on to the next step until the step they're on is completely resolved and that it elicits no fear whatsoever. Then they'll move on to the last step. And the last step might be something like the therapist and the patient buying a ticket and flying someplace and flying back. And so each rung is a little bit higher of anxiety and higher of fear, but it's resolved, and then they move on to the next higher one, and they keep on until they eradicate the phobia. Now, this is just exactly what I was talking about. Certain people will do well on Mayo Eyes or imipramine. I'm sorry, I'm wash my mouth and I can't do a thing with it. Also mild tranquilizers like benzodiazepines. And again, we go to that so often when we don't need to. Then we have what's called social phobias. Social phobias, it's anxiety disorder characterized by an overwhelming fear and excessive self-consciousness in everyday social situations. Now, social phobia can be limited to only one type of situation, such as a fear of speaking in formal or informal situations, eating in front of others. In the most severe form, it may be so broad that a person experiences symptoms almost anytime they're around other people. Signs and symptoms: people with social phobia, they will have a persistent, intense, chronic fear of being watched, being judged by others, being embarrassed, being humiliated. Now, this is not to be confused with paranoid disorder. This is just an anticipation, and they are not feeling they're plotted against, but that something that could happen to embarrass them in front of these people, and so they're very fearful. The fear may also be so severe that it interferes with day-to-day living. The physical symptoms can also include blushing, profuse sweating, trembling, nausea, difficulty talking. All right, here is the DSM-4 criteria. We do not use that now. Your DSM-5 criteria is in your book. All right, while research to define the causes of social phobia are still ongoing, some investigations will implicate a small structure in the brain called the amygdala. And they think that maybe that's where the symptoms of social phobia might be associated. The amygdala is believed to be the central site in the brain that controls fear responses. Animal studies also suggest that social phobia can be inherited. In fact, research supported by the National Institute of Mental Health identified the site of a gene in mice that affects learned fearfulness. Also, look at that, it says learned fearfulness. So it can be a behavioral thing. One line of research is investigating a biochemical basis for the disorder. Scientists are exploring the idea that heightened sensitivity to disapproval may be physiological or hormonally based. Other researchers are investigating the environment's influence on the development of social phobia. People with social phobia may acquire their fear from observing the behavior and consequences of others, a process called observational learning or social modeling. And this is what I was talking about earlier. Pardon me. Two types of treatment. Cognitive behavioral therapy, certain medications. Also, you can't, well, with the cognitive behavioral therapy, that does include the behavioral component. Your SSRIs and your monoamine oxidase inhibitors, as well as your benzodiazepines. I sure do stumble over that word. Some people will form a social phobia called performance phobia, and these have been helped by beta blockers. These beta blockers are commonly used to control high blood pressure. Then we have post-traumatic stress disorder. Now, in the 1960s, they basically thought, okay, this is brand new. And then they got to thinking about it and said, no, it's not. In the Civil War was when we really first started seeing it. Excuse me while I'm running. There we go. Okay, but in World War I, we actually started calling it shell shock. Then in World War II, we started calling it battle fatigue. With Vietnam, they at first called it the post-Vietnam stress syndrome. Also, there are some therapists that believe a form of PTSD can occur after abortion, and that's called post-abortion syndrome. Post-traumatic stress disorder is a type of anxiety disorder that's triggered by an extremely traumatic event. A person develops PTSD when a traumatic event happens to them or to somebody that they are very, very deeply involved with, or when they see a traumatic event happen to somebody else. PTSD can affect survivors of traumatic events such as a sexual or physical assault, such as a rape, being in war and seeing what war really is, being tortured or seeing somebody being tortured, a natural disaster, an airplane crash, and many people actually develop post-traumatic stress disorder after the World Trade Center World Trade Center attack. And the people that were working, trying to find survivors and working through that and seeing the carnage, seeing horrible, horrible things, they were deeply, deeply affected, and many of them developed PTSD. Now, I'm going to try to upload an individual's testimony. It was a firefighter's testimony about being involved in 911. PTSD can also affect rescue workers, as I was just saying, at the site of a mass casualty or tragedy, and they can incur horrible things, and some of these things can cause intense fear, helplessness, or horror. Okay, DSM-4 criteria, I'm not going to go through. You can go to your book and look up the DSM-5 criteria. Traumatic events that may cause PTSD include violent assaults, kidnappings, torture, being a hostage, a prisoner of war, experiencing a disaster, being in a bad car accident, or getting a diagnosis of a life-threatening disease. Children can develop PTSD symptoms by experiencing sexual trauma, things like age-inappropriate sexual experiences, witnessing trauma experiences. Learning about these experiences also may cause PTSD symptoms. Facts about PTSD: it can affect anybody at any age. Millions of Americans have PTSD, and millions get PTSD every year. Many war veterans have PTSD. Some of them don't realize that's what they are experiencing, and women tend to get PTSD more than men. Now, I had a patient come in with PTSD, and he had served in the Gulf War. And the way his developed was he was driving the last truck in a convoy, and they could not have their lights on at night because of the fear of being attacked. And so they had to try and follow the truck in front of them. And he apparently zigged when he should have zagged. And when dawn broke, he found out he was all by himself. And he was very, very fearful of either having somebody aim at him with a mortar or some kind of device, or actually being overrun and captured. And so he was extremely scared, and he turned around and followed his tracks and saw where he got off the trail, and he came on back. But he suffered PTSD. The seeds of PTSD at the minimum, and then when he came home, he was involved in a car accident where it resulted in a person dying in the accident, and that was the final straw. And he developed a case where when he came in to see me, his wife had to move into another bedroom because he was attacking her at night and beating her and hurting her. And so these things are this thing is not anything to play with. In the United States, 60% of men and 50% of women experience a traumatic event during their lifetime. Of those, 8% of men and 20% of women may develop PTSD. A higher proportion of people who are raped will develop PTSD than those who suffer any other traumatic event. Because women are more likely to be raped than men, this helps explain the higher prevalence of PTSD. But again, when we're dealing with something like this, you always have to worry, are all the men that are having these problems, are they getting help or trying to suck it up and be macho? 88% of men and 79% of women with PTSD have had another psychiatric disorder. Nearly half suffer from major depression, 16% from anxiety disorders, 28% social phobias, and they are also more likely to have risky health behaviors such as alcohol abuse or alcohol dependence. Alcohol abuse affects about 52% of the men with PTSD and 28% of women. Drug abuse is seen in about 35% of men and 27% of women with PTSD. More than half of the Vietnam veterans have experienced symptoms of PTSD that we know about. Although 60% of war veterans with PTSD have had serious medical problems, only 6% have had a problem due to injury in combat. African Americans, when they're exposed to trauma, are more likely to develop PTSD. Patients who regain partial consciousness during surgery while under general anesthesia are at risk at developing PTSD. Now I'm going to see if I can find some more of the symptoms, because it is significant. Now, even though this is a DSM criteria, remember that the DSM-5 is in effect, but I wanted you to hear some of the symptoms of PTSD. Well, exposure to a traumatic event, re-experiencing that event persistently, such as having flashbacks or nightmares. Avoidance of stimuli associated with the trauma. So somebody who's been in war may not want to go to a fireworks display because it would remind them and throw them into a flashback maybe because of the explosions. So they'll avoid that. Persistent symptoms of increased arousal, hypervigilance, startling easily, being kind of on edge constantly. So all of those are symptoms, and again, I'm going to try to upload a video of a person who has suffered PTSD and hear what she's gone through. All right, obsessive compulsive disorder. OCD, this is characterized by, it's an anxiety disorder that's characterized by recurrent unwanted thoughts, that's the obsession, and repetitive behaviors, which is the compulsion. So you can be obsessive without being compulsive, okay? So recurrent unwanted thoughts, constant thoughts intruding into a person's thought patterns and into their head. And then sometimes it will even go further to manifest itself in repetitive behaviors called compulsions. Okay, repetitive behaviors such as hand washing, counting, checking, cleaning. These are often performed with the hope of preventing obsessive thoughts and making them go away. Performing these so-called rituals only provides temporary relief, and not performing them will cause anxiety. I had a patient that she prayed 200 times a day. She was a Christian, and she said she had to pray 200 times a day. And I said, well, what would happen if you didn't? And she said, I know this doesn't make sense, but if I don't pray 200 times a day, somebody in my family is going to die. And so she had this fear, this unreasonable fear that she knew was unreasonable, but she had to perform this ritual 200 times a day, or else she felt she would be responsible for her one of her family members' death. The obsessive compulsive disorder is a significant neurobiological disorder that can severely disrupt academic, social, and vocational functioning. People with OCD may be plagued by persistent, unwelcome thoughts or images, by urgent need to engage in certain rituals. They may be obsessed with germs, dirt. They may need to wash their hands over and over. They may be filled with doubt and feel the need to check things repeatedly. I had a patient in the hospital, and I walked in, and she had all the towels on her bed, and she was folding all the towels. And they had to be in a certain way. All the corners had to touch a certain way. They had to be folded a certain way. And she finally got them exactly the way she wanted, and she was going to put them into the closet where she was keeping them. And right as she placed them there, something happened, and she goes, oh no! And it wasn't perfect. And so she pulled them all down, unfolded every one of them, and started all over again. OCD is now believed to affect as many as 2% of the children. In the United States, obsessive compulsive disorder is substantially more common in children and adults than once believed, and has a 6-month prevalence in approximately 1 in 200 children and adolescents, while the prevalence of OCD occurring at any time during childhood is assumed to be 2 to 3%. The modal age of onset, 7 years. The mean age, 10.2 years. These figures will imply that the possible existence of an early onset group and second group with onset in adolescence. Boys are more likely to have pre-pubertal onset and a family member with OCD or Tourette syndrome. Girls are more likely to have the onset of OCD during adolescence. OCD is more common in whites than in African Americans, and epidemiological data suggests no differences in prevalence as a function of ethnic group or geographical region. So we know that it really is not an ethnic or cultural phenomenon. Causes: OCD is considered a neuropsychiatric disorder. OCD symptoms do not appear to represent intrapsychic conflicts within individuals. Indeed, relatively few OCD behaviors exist, and they are experienced in much the same manner by patients regardless of their interpersonal histories. Investigators have found OCD symptoms arise from or are strongly exacerbated in the context of a beta hemolytic streptococcal infection, which has been given the acronym PANDAS. Now, what this says is, and this might blow your mind, one cause, not a cause of every OCD, but one cause is having streptococcal infection, like a strep throat when you're young, and not knocking out all of the bacteria, and later on in life it presents itself as OCD. Sudden exacerbation of OCD symptoms in the presence of upper respiratory tract illness will mark these kind of cases. The mechanism is believed to be caused by an antineuronal antibodies formed against group beta hemolytic streptococcal cell wall antigens, and they cross-react with neural tissue and initiate OCD symptoms. Okay, I'm not going to read that one. Care. Successive treatment of this chronic disorder involves both judicious use of SSRIs, which are antidepressants, structured psychotherapy, usually cognitive behavioral or a form of it, and these are designed to provide the patient with the skills to overcome and to control obsessive thoughts, and then therefore accompanying compulsive behaviors. Again, cognitive behavioral therapy is routinely described as the psychotherapeutic treatment of choice for adults, children, and adolescents. Treatment relies heavily on exposing the individual to the problem situations and then preventing the compulsive response. The resulting anxiety then is managed by training to use strategies that help them work with their anxiety in a more effective and less disruptive way. And again, this is the treatment. We say CBT, it can be CBT or a form of cognitive therapy. So CBT or cognitive therapy and pharmacologically, pharmacotherapy work will work together in tandem. Now, I have a film I'm going to try and upload on an OCD patient talking about his, and he puts more stock into the antidepressants rather than the therapy itself, saying that when he started taking them, there was a dramatic decline in his symptoms, and when he forgot his medicine and he went on a trip, the symptoms returned quickly, which says that we're not curing it with the medication, we're certainly just controlling it. And that is the conclusion of the anxiety disorder slides for the chapter, and I will try to upload the second part ASAP. Have a good day.